Thank you, everybody, for joining us today. We're super excited to have our next monthly functional weight loss discussion. Today, we're going to be talking about continuous glucose monitor and how blood sugar imbalances impact our metabolic health. And obviously, we have a guest speaker today that we're really excited to introduce you to, which most of you probably already know who she is. But for the sake of introduction, I'm going to go ahead and start out with introducing myself and Erica, who are moderating this presentation. So my name is Sherry Stoka. I am a registered dietitian, functional nutritionist. I've owned Weight Loss MD and Wellness for the last 10 years. It's a a medical weight loss and wellness business. And Erica Gutierrez is also a registered dietitian nutritionist. She's also an integrative practitioner. And she has been basically with me since the onset of opening my business back in 2015. So we have had just incredible experiences in being able to work with people on, weight, their weight issues. And so Weightless RD, we created about 6 months ago, and we really wanted to create it. Really, I'll just get to our mission and then everything will kind of fall into place. But our mission is to unite dietitians and functional nutritionists to reshape the future of weight management. We are the experts, meaning dietitians, functional nutritionists. We will be the ones that drive profound change in this chronic disease and obesity epidemic. There is a lot of misinformation out there as it relates to weight loss. And in the last couple of years, the misinformation has just perpetuated, this market. And so really our mission is truly to get, information out there to educate people. Dietitians obviously are the critical players in weight loss. And it's said often, that we need to look beyond calories and exercise, but it's so much more than that. The majority of people are dealing with, weight loss issues, weight loss resistance. So we really must understand that weight loss is multifactorial. And so that's why we've taken the functional weight loss approach, really looking at the whole body, the different components, because, again, the days of like meal planning and telling people to exercise are so gone. GLPs are the future. And again, being the owner, the only dietitian who owns a medical weight loss business, we offer the GLPs. And so we've learned so much over the last 5 years. And so now we're very passionate about sharing our knowledge and kind of, helping to put all of those pieces together, as we approach this new era of weight management. So the agenda for today, we're going to talk about blood sugar management and weight management, the beginning of blood sugar dysregulation. We'll talk about who is a good CGM candidate, the interpretation of a CGM, the root causes of blood sugar and insulin issues, how to address metabolic health. We'll talk more about our course, our GLP course for dietitians, and then we will end with a discussion. We hope to leave a good amount of time at the end for open discussion. So we also, want to encourage you to ask questions during the presentation because we will answer those throughout rather than waiting. That's also an option. Okay, so why are we talking about blood sugar dysregulation today? It is probably one of the most important pieces to the root, kind of like the root cause. And it is not talked about enough. It is often missed early on. And I say it all the time, that obesity is, doesn't cause all of these chronic diseases. Obesity is the result of long-term metabolic dysfunction. So if we can identify and we can start to focus and do more prevention early on, we can, be in a better state of health and not dealing with the obesity statistics that we're dealing with. So that's kind of the goal of this. You know, when if blood sugar management is not a part of, kind of like the whole picture of working with patients. Again, you could find yourself down the road. Now the patient is in a sicker state and there's more weight loss resistance because the body will switch gears. If you have blood sugar dysregulation or hyperinsulinemia, the body goes into a fat storing mode, and it's almost impossible to access those fat stores. So I just wanted to kind of start with this very simple slide and just really reinforce that, it really does start with the dysregulation. And obviously, we're going to talk more details about all of that. So Karen Kennedy is going to be our guest speaker today. And she's going to be sharing her slides. She's going to introduce herself to you all today. She is absolutely my go-to as it relates to CGM, and we've kind of, worked together throughout the years. So I'm really excited to have her come on and talk to you all. And as you can see, there's a poll there. And Karen, I'm going to let you take it from here. So I will stop sharing.
We wanted to get a quick look at where people are at with their CGM experience. And it looks like, wow, okay, so about half of the people here have personally used one, which I think is such a great way to learn about it with that hands-on experience. I have a couple that have no experience, a couple that have recommended them. We're kind of all over the board, a little bit of everything.
Good. Well, that's how we learn. I always tell people when I'm training other dietitians that the first thing to do is just put your own CGM on and learn how to do it, because it'll help you support other people. So thanks for inviting me. And I got to tell you guys, one reason I love working with Sherry and Erica is Sherry's the one who really schooled me in GLPs. She's my go-to person on that. But more than that, I feel like we are really kindred spirits in the, we really enjoy that peer education, helping as we learn things, sharing that information with our peers so we can elevate our whole field. So that's why I love Sherry. And she's so good at what she does. And like she said, I think these CGMs aren't the be all end all. They're not the be all end all. But when it comes to weight loss, blood sugar, if you ignore it, it's going to get you stuck. And a CGM use for some people, for some of the time, can be just a really nice tool. So what I'm going to tell you today is, here I am, nutritionist, no disclosures, nobody pays me. Nobody pays me. I'm going to give you a 10,000-foot view of kind of, I want to show you a little bit about what it's like to support a person who's using GLPs with a continuous glucose monitor, specifically in reducing their other medications. Because a lot of time that's what's going on is they'll be on a lot of hypoglycemic medications and a GLP-1 will come on and we can use that to reduce their other meds, especially insulin. But I think I want to make this practical. So I'm going to do like a 10,000-foot view of a case study of the first person I ever supported using Ozempic, and then go into the nitty-gritty of what it looks like so you can get an idea. And I always start with this slide because, like, is this really going to help my patient? Can I do this? And I know a lot of dietitians who kind of use them themselves but really hesitate to then bring them to their patients. And I want to encourage you, if you're that person and you just haven't made that leap, find a patient that you get along with and you think is tech savvy and just try it. Just try it with one person. So again, I'm going to do a 10,000-foot view and then go into more detail. So I had a patient a number of years ago. This is before I met Sherry. And we all had our first patient who was on Ozempic, and we're like, oh, I think I get this. I think I understand how it works and how to support it. So sure. And then, of course, after I did this a while, then I met Sherry and she kind of schooled me on stuff, and that's how we got to be friends. Anyways, So let's talk about this patient. I met him a couple years ago, and he wanted to get off insulin in about 4 months. Or we got him off insulin in about 4 months. So he's a 55-year-old man. He'd had type 2 diabetes for 10 years, so he had all the underlying metabolic issues, but he would be a classic metabolic syndrome. He had hypertension, hyperlipidemia, obesity. He was this close to getting his gallbladder removed. And he said, I want to lose 100 pounds and keep it off, and I want to get off insulin. And this was a guy, he ran a huge company. He traveled a lot and he worked a lot, but he had a lot of support. His whole office staff he was really close to was supporting him. His wife was supporting him. So it was all in his favor. But he was really having a tough time. It was really stuck metabolic health. I mean, so good on his doctor for prescribing it. He was an ideal candidate for GLP-1. I didn't know that at the time, of course. I was just kind of jumping into this blind. So when he was starting out, he told me that he was on a basal insulin 78 units per day. And he was on Ozempic, metformin. He was on a couple of blood pressure meds and a statin. And his A1C was 9.4. And the reason we wanted to drop insulin is, as Sherry mentioned, we knew that he had hyperinsulinemia because of all of his metabolic syndrome symptoms. He had the symptoms of that elevated insulin drives. And so we wanted to be really aggressive in dropping his exogenous insulin to aid his weight loss. But we don't want him to go hypo, and we don't want his blood pressure to go high. Obviously we want to get him off insulin, but we want to keep him safe. And that's where a CGM is just a no-brainer of a tool for that. And I'll show you what it looks like after this. Sherry went through this. How is blood sugar involved in weight loss? And there's two things that are important to note with weight loss and blood sugar. And one of them is better served by using a CGM than the other. One is indirectly, because through chronically elevated blood sugar, or if you're just sort of snacking and keeping that, steady stream of carbohydrates coming in all day, you're keeping your insulin levels up longer and it never has time to go down, so you can shift into a different metabolic state. So indirectly, we can infer by looking at someone's glucose, we can think of what their insulin might be doing. So we regulate glucose, get it better controlled. We get more time where insulin is down on the floor. But the other one, I don't know if you thought about this, was that more extreme blood sugar swings increase cravings. And this is in the literature, some people more than others. You've probably seen patients, if you screen for this, where they get hangry. I have a question saying, do you get hangry? And like, oh yeah, I get hangry all the time. And to me, hangry is blood sugar's dropping rapidly and adrenaline's coming up because it's dropping too fast or too low. And that's just going to drive the hardwired need to eat again, snack, or, get your blood sugar jacked up again and do that all day long. And we can see that and we can control for that with the CGM. So my goal is to minimize the variability of glucose and lower insulin levels between meals and overnight. And just going to jump to the chase here. In the first month, we managed to control his blood sugar with current meds. We didn't change any medication right at the beginning. But really, by the end of the first month, he had to drop his insulin from 78 to 64 units per day. So he was already seeing a drop in that, just trying to control his blood sugar. And, he had typical type 2 diabetes numbers. So if you're already using a CGM, or often try to keep people in that Goldilocks zone of 70 to 140. And even if people have type 2 diabetes, that is my goal, 70 to 140. And he wasn't even coming below 140. Like 140 might be his low, his fasting level with where he was at. So he's starting to drop down a little bit. So he needs less insulin. And using the CGM, we could see the strategies that worked for him were, he reduced his carbs. He had to reduce his carbohydrates. He had no tolerance for carbohydrates at the time. We increased his protein to the adequate protein for his size. And he couldn't do a lot of exercise, but he could walk during phone calls. He's kind of a busy go guy. So when he was traveling and he had a phone call, earbuds in, and he would take laps of a building if he was traveling. He would just walk. And the other one is that he had sleep apnea, and he was using a CPAP sometimes. And we saw in a CGM that when he used a CPAP, his blood sugar was way better. So we intervened and we got him in for a better fitting mask and then made it so he was committed in using his CPAP more like 90-95% of the time. That was our intervention. He wasn't lifting weights yet. That took us 9 months to lift weights. That was a hard sell for him. Anyways, he basically kept his blood sugar in the Goldilocks zone, 70 to 140. And as long as he was doing that, we dropped 5 units a week of insulin, at least. And that's something we worked out with his nurse. I asked him to talk to his nurse and said, what are the parameters? How quickly can we drop insulin? And so we did at least 5 units a week. And by month 5, he was completely off insulin and down 70 pounds. So the beauty that I've seen of using Ozempic with a CGM is, of course, the GLPs really help a patient manage his overeating. And this is something I learned, this language I learned from Sherry is using Ozempic to just help people do what we want to help them do in the first place. Like we're doing all this integrative stuff, but it's so hard, and the Ozempic makes it easier. And it addresses some of the underlying metabolic things at the same time. So that just made all this so much easier for him to just not overeat. And so he found it easier to reduce his carb intake for the first 5 months. Then we actually brought it back up. It's likely the GLP potentiated his own insulin production, helping us to drop the exogenous insulin. And most importantly, the CGM helped us drop insulin safely and aggressively. Like we were really aggressive with insulin dropping, but we could do that completely confidently. So let's see how this all looks on a CGM. And I don't know how many of you, if you want to drop it in the chat, when I use CGMs, for a long time, I only supported the Freestyle Libres. And occasionally I would support a Dexcom G7. And once the over-the-counter CGMs came out last year in August, then I started supporting a Dexcom Stellos. And for dietitians, that's, it doesn't require prescription, so it's easy to use, but I still help people get prescriptions. It's not hard. So you're going to see data that looks a little differently depending on what I'm using, and I'm happy to answer questions about that. So here's a picture of another patient. This is type 2 diabetes for someone, and this particular, you're going to see this, and you're going to see patients, of course, who are on multiple hypoglycemic medications, metformin, glipizide, Jardiance, and insulin. They're usually on sometimes 2 or 3 of these. And you can see, big areas under the curve. And, in case you haven't seen these graphs before, this is from a Dexcom product, and you're viewing it on Dexcom Clarity, which is a free desktop app that you can have as a provider, a free app, and your patients can share their data with you. This little gray zone here between the 2 red lines, this is 70 to 140 milligrams per deciliter glucose, and this is our target range. And you can see, and what we want is blood sugar overnight to just be like, around 80, just kind of bottom feeding around 80 until they eat. And then ideally they would go up to, stay under 140-ish for a meal and then come back down in a couple of hours and then be down on the ground again. But you're not seeing this. You're seeing people go well above 140 and stay up there for hours. And so that's type 2 diabetes. That's your type 2 diabetes with the person eating a lot of carbohydrates and not eating much protein or fiber. That's what this is. So that same patient that you just saw, let's look at those dates. So you see, these are the dates. This is a different patient than the first one. December 28th, 2024. This is an actual patient. This is how it looked for months while we were trying to tweak his diet. So that was end of December, and this is early March. Same patient, type 2 diabetes, same medications. And now he's almost 100% on some of these days in that range. You can see he's still elevated at night, somewhat, when he's not sleeping well, but it's a big difference. Now, when you are supporting your patients and they're on a lot of medications and you want to start dropping them, and you're using a continuous glucose monitor to do that, this is the place you want to get to, and then you start dropping medications. And before I go saying some really authoritative statement like that, I should say I am basing this 100% off of my clinical experience because I haven't had anybody else to show me how to do this. But it's logical to me that you want to make sure you have good control and then you drop a medication. And I have seen that when we do that, blood sugar will jump up a little bit. But if we're this controlled with multiple medications, then we have wiggle room to drop that extra medication and then it might jump up a little bit. And then we wait and we, get it back down to here, drop a dose, might bump up a little, but we're still in a really good zone. And then it comes down a little. So in a way, we can be both conservative and aggressive. We can pace it just perfectly for them. And everyone feels confident. The prescribers feel confident. The patient feels like they're going as fast as they can. And you're trying to keep that insulin down the whole time by regulating that glucose. And for numbers wise, what I use is I want blood sugar to be consistently below 140 mg per deciliter. And I want their fasting levels ideally to get below 100. And you can see here that this person's fasting levels are, at or below 100, and that's good enough. You might find, and I should say that this is my experience, and I only have so much experience. If you're doing this with your patients, you might try it at a slightly different pace. You might be comfortable in slightly different reference ranges. So Sherry went over this a bit. The reason we're concerned about elevated insulin is it drives fat storage, particularly in the viscera. And it's hard to tell what insulin's doing. When you're looking at a CGM, you're looking at glucose. So all I can do is infer what insulin is doing. But I can infer based on some clinical signs and symptoms, the symptoms basically of metabolic syndrome. But I might get a fasting insulin, which may or may not be elevated yet because, by the time they wake up, insulin might be down again. But I'll still ask for fasting insulin. I'm looking at triglycerides. If they're over 100, I'm definitely thinking, yeah, insulin's a little too high. I think 150 isn't a cutoff that I like. It's not hard to get people. When I use a CGM with people and they get better blood sugar control, we're a couple months away from cutting their triglycerides in half. If they're 200, we're getting them down to 100 in under 3 months. It's a very quick shift for them. But I should say that I have read the literature. Is it called the insulin or triglyceride paradox, that people of African descent, if they have elevated insulin, their triglycerides might not be elevated. So that's not a good marker for Black people, for people of African descent. Oh, come on, Karen. And then of course, VAT. It's great if you can get a DEXA scan to actually assess visceral adipose tissue or in-body. Sometimes you could just use a waist measurement, but those are the markers I use to help me infer, is this insulin? Because one thing that's frustrating is you will get patients who have obesity, significant obesity, and some metabolic health issues. You'll put them on a CGM and go, oh, blood sugar is going to be all over the place. I've seen this a number of times. And their blood sugar is gold. In fact, it's so gold that they could eat like a turkey sandwich with 2 slices of bread, which most people, unless you're like a 15-year-old soccer player, that's just going to be you're going to see it in your blood sugar. And I remember there's a woman recently who just exemplified this. She just had this blip, just a very gentle rolling hill from eating a sandwich with 2 slices of bread. She had obesity, she had high blood pressure, she had all the things. And I realized, a CGM is a poor metric for you. She's producing so much insulin and she's insulin sensitive enough that it's getting disposed, but we needed tighter control. And I've seen people like that before who, when I first started using a CGM and I saw their blood sugar, I'm like, looks okay. Blood sugar might not be an issue for you. But then when I started running group programs and people would just sign up and I had them for 4 weeks and I would look at their blood sugar and go, wow, kind of wasted your money, buddy. But you're here now, so you might as well do it with us. And sure enough, that perfectly reasonable looking blood sugar, when they started tightening things up a little bit and doing all the things, They felt less hungry. They slept better. They're like, I haven't taken ibuprofen in 2 weeks. Joint pain went down, lower inflammation, and then they started losing waist because I always had them measure their waist. So I've learned that, glucose doesn't tell the whole picture. Anyways, I'll talk more about who this is good for. Let's talk about wide blood sugar swings. So like I said, wider blood sugar swings leads to more cravings. And of course, if you're using GLPs, one of the things you're trying to control is that craving. You're trying to reduce that food noise. And on a CGM, if their blood sugar is going up and down wildly, if they're a good candidate, they're not like the woman I was just describing. There's some metrics you can look at besides just looking at the raw data and seeing it go wildly up and down. So you can look at the monitor data wildly going up and down, or you can look at the CV, percent CV, and keep it between 12 and 15. And I'll show you what that looks like on the CGM data. So if you're using a Freestyle Libre, you're going to be looking at LibreView. That's the software that you use to see the back end of your patient's data. And if you're using a Dexcom product like Stelo or a G7, you're doing a Clarity. And it always gives you this readout, average glucose, GMI, which is supposed to be roughly similar to your A1C. And then both will have a coefficient of variation, which relates to the standard deviation and the mean glucose. And to have a good tight control that's reasonable is generally under 15. Like 11 to 15, I think, is a good coefficient of variation. Some people need it lower. So if somebody's blood sugar, you're just like, like the gal who wasn't a good candidate because her blood sugar wasn't responding, but I knew she had high insulin, I would say we need to keep her CV, coefficient of variation, closer to 10 to make a difference for her, or just go straight to there's a certain amount of carbohydrates you can have and manage it that way. Most people can get away with under 15, and that's a good enough variation for them. I will say now that, I'm being really general. We're not talking about athletes, but if you get athletes, if someone's training for big endurance events or really high intensity training, they will have a much higher coefficient of variation because they're fueling with more carbs and their blood sugar goes up dramatically when they're training hard. So completely different for athletes. So we're not going to talk about them, but don't take the tight CV into your sports nutrition world. So how is a CGM handy? Because they are handy. And I want you to know that this is a handy gadget. It's just like any other lab or tool. It's not perfect. It's not going to save the world, but it's a handy tool. You're kind of spying on your patients. Yeah. All the food logs in the world, you're still like, well, I think they're telling me what they're eating. You get to see everything that's happening. You don't just get to see what they eat. You get to see their response to stress. You can see how sleep affects it. Like I can look at this and talk to somebody and go, I think you have sleep apnea. You need to get checked. And I can convince them through the data to go get a sleep study done. So you can really see all the variables affecting their blood sugar. They know you're paying attention. And so it's this little, it's a nice accountability. For some people, that causes too much stress and it really pushes, a little bit of eating disorder behavior. But for a lot of people, it's great. You and the patient can connect blood sugar with cravings. Like you can be looking at their data with them and you can like, oh, I see this. Oh, and I can see that you then had a donut. And say, that makes so much sense. Of course you had a craving for sugar because look at what was going on the rest of the day. That's how your body works. So let's see if we can prevent it. So it depersonalizes that whole thing. You say, okay, you're hardwired to like crave some sugar once your blood sugar does something like that. So let's prevent that. And then you won't have those cravings anymore. So it connects the dots. You can get tighter blood sugar control. And it gives your patient agency, like it gives them control. They can see what's working, that's what I like. So, and in that way, it creates this more of a coaching relationship with your patients. I think the combination of using a CGM data on a Zoom screen together and some motivational interviewing skills is like a really great way to start putting things in their court and ask them about the change language rather than us just tell all the time, which is, what we're programmed to do. How is it not helpful? So the first one, as I said before, if insulin is high, blood sugar levels can look fine, and then it makes it not a helpful metric. And I hope that makes sense to you. Some people with elevated insulin levels and obesity have really good blood sugar control. And then, of course, it's not helpful if you have, the subject of eating disorders always comes up. And I think with eating disorders, I have seen that to be a mixed bag. Sometimes, and this is where you just need to use your professional opinion. For some people with eating disorders, it can help them see the connection between their mood and cravings. Eating disorders, there's a lot of psychological issues with that, but some of it, as you know, if you can take out some of the physical triggers like blood sugar, that can just make it a little bit easier to not binge eat, like for binge eating disorder. So for that, you can start, again, like making it less shameful and saying, let's look at the physiological issues behind binge eating. But then again, and these are over the counter now, so anybody can get them. And I would prefer to be supporting somebody on them and teaching them how to use them and be skillful. And then say, okay, we've got what we need. We've learned what your triggers are. So let's take off the CGM and then just figure out how we can support you doing these things, walking after meals, using your CPAP, planning your meals. The CGM tells you what the 2 or 3 things that are going to be the most helpful, the kind of 80-20 rule. And then you use the skills you've been using all these years to figure out how to help them do those things. Get a personal trainer, go get a sleep study, do the supplements that you need for this. God, and this is my first stopping point. So I hope this gives you an idea of how you can use a CGM along to, help them get off their medications, help them draw those conclusions themselves between what causes cravings and what spikes their blood sugar, gives your patients a lot more control, and a little bit about where it doesn't work. There's a lot of nuance in here. I can't give you you're looking for this is the range, do this, not this. And I have some other slides, but there's so much variability in glucose response. There is so much variability in insulin response, patient to patient, that you have to personalize it. But when I say you need to personalize it, I want to underline the word person. You have to deal with the person and meet them and use a CGM as more of a coaching tool to help them understand their bodies.
Thank you, Karen, for that. I personally have so many questions. I have patients on them. I've used it, and we'll get into that in a minute. First, I want to throw out another poll, and Sherry's going to pull some slides back up. I'm really curious because we were here obviously talking about the CGM and how they work with GLPs. What is all of your personal experience on GLPs? Your interest in learning more, that sort of thing. Okay, so a bunch of people right off the bat, some experience, interested in learning more. Yeah, I think this is an area, and Sherry and I have been really lucky to have been in on this field really early. And we were hesitant to begin with. We were doing everything functional weight loss, and we did our own studies right off the bat. Can this actually make a shift and a change in their metabolic health, or is this just another medication that's a Band-Aid? So we were really skeptical in looking at that. Now, after how many years has it been? We have had thousands of patients and can really give you guys a lot of insight into this. Okay, most people say they have some experience but interested in learning more. A few that say they've had extensive experience. Okay, awesome. So what I want to talk about just real briefly today is something that Sherry and I are really excited about. This is going to be our second live launch of our GLP Dietitian Expert course. It's 6 weeks long. We do live sessions every single week. I think one big thing we've heard from people from the past is they loved our ready to use resources for patients. You know how long it takes to create these different materials. And so we have done all of that work for you. We want during these sessions for you guys to bring your difficult cases to us, and we're going to talk about them and collaborate together. That's how we learn. We're going to give options for you guys to have future talking positions in these RD discussions if you're interested in that. And we're really excited because we are in the process of CE approval for our course. So what we wanted to do today, and this will be good till tomorrow, is offer to you guys $100 off. So the $299. There is a QR code, but I will also put the link in the chat. And you can see the outline of what we go over. Sherry does a lot of the really sciencey stuff. I go into the nutrition aspects and what we have found that works. We talk about weight management strategies specifically to these GLPs because it really is a unique animal and the struggles that these patients go through. We do our case studies so you can see. I think a lot of people are scared to go off of them. We don't encourage people long term if it's not needed. So we help people work off of these medications and think that's important. And then with Sherry owning Wayless MD, you know, she is always on top of the trends. She's doing new studies on the newer medications. So we have a lot of insight on that as well. Okay, so I feel like our profession is so heavy. We deal with a lot of really difficult things. So I threw some memes in here. I was trying to think about, okay, why did Sherry and I decide to put this course together? And just so you know, we have this bigger community. So we want to hear from intuitive eating dietitians. We want to hear from eating disorder dietitians. We want to hear from everybody. And part of what we're doing this for is we want you to get ahead of the curve. I know as I'm getting older, I like to stand out. I never used to. And what you see in research is we're way behind. We're not able to help our patients at that point. The second one I just found really funny, and this is what media says, is, you know, all these symptoms, all these issues. We haven't seen that in our patients. And whether you like the GLPs or not, that's like a whole separate discussion. 1 out of 6 people are on these medications. So how are we going to choose to work with our patients or not? And let's advance our profession, you know, let's stand out there. And then, man, this could have been me years ago trying to do everything myself and move that couch. But if we all come together in a like-minded community, I think we can go a lot further. Okay, so if you guys want to put anything in the chat or want to speak up, feel free to. So Karen, I have a question that I want to ask. And I think you covered it a little bit with maybe it's the insulin levels, but I've had patients that just will not go under 100. And it's like that overnight time frame, they stay a little high and I can't get them under. Do you have any suggestions for that?
Yeah, yes. Well, no. That's hard. There's a lot of different reasons. I mean, I was just did a roundtable discussion on this, like why is my patient's baseline glucose level staying elevated? It can be a lot of different things. The obvious one is, you know, when you have somebody who's just has poor metabolic health and their liver is stuck in gluconeogenesis and is cranking out the glucose. But why? Do they have fatty liver? Some like if you're seeing it primarily at night, let's look at that one. You see at night, their fasting glucose is just staying elevated. You can't get it down. Are they not sleeping well? And you have to kind of do this like root cause assessment. Do they have sleep apnea? Do they have pets keeping them awake? Is their partner snoring? So is it that? Because that can bring up the baseline. So it's because it's either, I'm always thinking it's either cortisol. Elevated cortisol causes the whole baseline to go up. Inflammation, because inflammation will cause the whole baseline to go up. or for some reason they're, high levels of just the liver cranking out glucose all the time. So sometimes I'll give you an example. I'll give you an example that this crowd will appreciate, and some of you might have heard it because I say it all the time. I call it the dietitian syndrome. When I'm training dietitians how to use CGMs and they put it on and I'm like, okay, go use it for a few weeks and let's get on a Zoom call, talk about your data, and then ask me any questions you have about this. And I like, how did it go? They're like, oh my gosh, my blood sugar, it wouldn't go under 100. Like it was fine. Like my meals were okay because dietitians eat perfectly and exercise and do everything perfectly because this is us. So they're fasting blood sugars cruising along at 100, 105. And they're like, why isn't it 80? Why am I not at 85? I'm like, everything else I'm doing is perfect. Talking at that speed, of course. And I'm like, well, that's interesting. I wonder if it's stress, but I'm not stressed. I know you're not stressed, but let's just think about this. And one time, I always use this example because I was monitoring this person. I recommended, why don't you do like a stress reduction thing and see if you can like just kind of put that in the evening. I always recommend do legs up the wall, the Viparita Karni yoga position. And we saw on her data when she did it, and her glucose never went down, I think like below 100, 105 or something. And for the first time, her blood sugar started going down. And it was when she was doing this relaxation pose, their legs up the wall, eye pillow on, set a timer. And since then, I have seen that in so many people. And I realized that, we all are wired a little differently, either because we came out of the womb with a more snappy nervous system or trauma or just in how we react. But even people who say they don't feel stressed, I'm sure my blood sugar's up right now because I am psyched because I like doing this kind of work and I'm talking and I'm feeling energetic. I got my coffee. I don't feel stressed. I've had a really stressful week. This is fun. But I know my blood sugar is elevated because I've got that kind of nervous system. And so sometimes I just have to educate patients of, I see everything looking good. All your metrics look fine. I think your blood sugar is just a little bit elevated. And I think it's because of your nervous system. And I don't think it's a freak out moment. If anything, maybe pay attention to your nervous system a little bit more, especially if you're a woman over 40, because it's going to catch up with you. But that's a long-winded answer to your question.
No, that's great. And I think you're right. There's so many different reasons, but when you pinpointed the cortisol piece, it tends to be those stressed out patients that I was thinking about with that number. So I guess also, could it partly be because of when they put it on, if they don't do it fasted, will that mess up the CGM if they have just eaten or they exercise?
When they install it?
Yes.
No.
Okay.
Now, when you install, the CGMs can be inaccurate. So can your glucometer. Any of those devices are, permitted by the FDA to be, what is it? This too, like up to 15% wonky. So, but an individual sensor, let's say sensor A, for its lifetime, maybe sensor A is going to be running 5% high on a good day. When you first install it, that first 24 hours, it's often very inaccurate. Most of the time it runs low. Some people it runs high for 24 hours. I had a patient that always, the first like 3 or 4 days, always ran high for 4 days and then leveled out. Just must have to do something with their immune system. And then so that's what I've seen. It's just the installation and your body getting used to it or whatever it is. It's just often inaccurate in the first 24 hours.
Okay. Thanks.
Karen, what is which of the models because I know that one of the models, the sugar, if a patient goes below a certain level, it just stops at a certain point. So you don't
That's
really
the
know.
Stelo. Yeah. So
Okay.
there's the two new models that are over the counter that your patients can just purchase online really easily is the Abbott Lingo and the Dexcom Stelo. I'm not supporting the Abbott Lingo because 2 things. They don't do it for Android and there's no back end. You can't support it as a provider. So that's just for people doing it on their own. The Dexcom Stelo, Dexcom chose to like cut it off at 70. So the patient can't see it low, but you can. because that
Oh.
data gets shared with Dexcom Clarity and it behaves just, it's a G7 in essence. So
Hmm.
we can see that, and you can set it up for your patient so they can check it on their phone using Dexcom Clarity, a free app, and then you can monitor that. But like I have one of my patients who has type 2 diabetes, and because he's using, I think it's Jardiance that will drop him down, we switched him over to a Freestyle Libre. And I said, let's just ask your doctor for a prescription. I sent his doctor a letter, he got it. And I switched him over. So anybody who does actually go low, not just having pressure lows, but real lows, I try to get them on a prescription one, a Freestyle Libre, which is still it's still cheaper. If you have a prescription, which is not hard to get, it's cheaper to buy a Freestyle Libre cash in a pharmacy than it is to buy a Dexcom Stelo online. That was more than you asked.
No, that was good. That was because I am working with a patient. I'm not managing her glucose monitor. She just had it, and she would say that she felt really bad one night, and her blood sugar went really low. And I said, "Well, how low?" She's like, "It stops at
It stops.
70." So that, that's not very helpful, because
Mm-hmm.
it's like, did she go down to 20? Did she go down to 30? But so I
Yeah.
was just curious.
Yeah, you would do the back end. You can always tell your patient they can use
Gotcha.
Clarity.
Okay.
It's very easy. And then you can also create a free practitioner account and see it.
Gotcha.
When you're working with a patient, how often do you meet with them in the beginning and then ongoing?
Yeah. Depends on the person, but most people who are new to this, and I will I have a little package. I want to use two sensors. And ideally, we would do it just 4 weeks in a row, or maybe 2 weeks and then a week off. But what I like to do is I have the instructions for how to install it and things like that automated. So, in a perfect world, to save them time and money, they will get it on 2 or 3 days before our first meeting. So they have a little bit of data, but not too much to get anxious about. And then we meet and I orient them to everything. I show them what their data should look like and how to log. And then I like to meet once a week for 4 weeks because I want to let them collect data and look at it, talk about it, and then each week say, oh, it looks like this. And I have that coaching conversation. So what do you think we should do? And we decide, well, let's try this. Have you tried walking after meals? So I find once a week for 4 weeks gives us, like for 25 minutes, those follow-up visits, gives us enough time for me to teach them how to be an expert at using the technology. And I can teach them how to interpret things. And we can get a good assessment on kind of their glucotype. Like, are they not producing enough insulin, or is it delayed insulin, or are they producing a lot of insulin and they're insulin resistant, or are they just eating too many carbs?
How often do you find that that blood sugar issues are related to non-food
Yeah,
things?
a lot. In some people, it's both, but it's all over the map. And I'll tell you that I seem to be attracting a lot of patients right now. This typically happens in women over 50 who are very smart, have been doing their due diligence all their lives. And then all of a sudden their A1C is 5.7, 5.9. And they're like, what the heck? I'm doing all the right things. There's nothing wrong with me. Why is my blood sugar up? Then they come to me and we look at it. And that's usually, well, sometimes A1C isn't a good metric for them. And I'm still trying to figure that out. But I end up saying, we're going to ignore your A1C or blood sugar. Everything looks fine. But I often see it. You'll see it with, yeah. Erica, isn't that you who told me about someone with type 1 diabetes who did MRT testing and lowered their insulin use?
Yeah, it was actually my daughter.
Mm-hmm.
She the doctors were not able, so I was really analytical as a dietitian too, and I was watching carbs, watching all the different things, and was not able to figure out why one time she ate X amount of carbs, it would do something, next time it wouldn't. So we did, and inflammation is a huge piece of it. The food sensitivities can be a huge piece of it. And in a type 1, you rarely see someone decrease their insulin needs. And she literally cut her needs in half
Mm-hmm.
when she went on that low inflammatory diet for her. Pretty crazy.
Yeah.
Mm-hmm.
Yeah, and we see this, you know, I was doing this all through the COVID crisis, whatever you want to call it. And so every time I ran a group program between like 2020 and 2023, someone got COVID. And we would watch their numbers. They're like improving, improving, and then their blood sugar never came below 140. It's as if they got a cortisone injection. And same thing, if your patients have some pain and they end up getting a cortisone injection in their shoulder for something, blood sugar's off the charts.
Yeah.
So
Well,
that's
meds are a huge contributor to that. I mean,
yeah. And so meds too. So the other one, I'll often get patients, women who've had breast cancer and are on that like a 5-year course of chemotherapy, like tamoxifen or another estrogen. What do you call it? I'm making a circle. What's the enzyme inhibitor? Testosterone to estrogen.
starts
Aromatase.
with a, yeah,
Aromatase. Why do I want to
aromatase. Yeah, okay.
aromatase? That's how I think
I
of
thought
it.
it started with a O. I'm like, I don't know.
Around aromatase. A lot of those will raise blood sugar. And so I've had someone come in and we couldn't figure it out. And I'm like, oh, it's this. It's this. And
Yeah.
but we could still get around that and improve it and bring her blood sugar down and help her lose weight. We just had to find out, you know, how to support it. So and same thing with there's some blood pressure medications that can do it, like oh, I just can't think anymore. Diuretics, thiazide diuretics will raise blood sugar. So sometimes you can say, I'll get someone on multiple blood pressure meds, and I'm like, can we drop the diuretic? Like, can we do that? And their doctor's like, oh, yeah, I don't know why they're on that, anyways.
Yeah.
And then we'll drop that just to get it off the table. And then, you know, because as we improve blood sugar, blood pressure will come down a little bit if that's one of the root causes for high blood pressure. So yeah, oftentimes. So I think when I'm going through sugar, I always, you know, always review their meds and even, you know, just a Google search, does this raise blood sugar and see if it can be a factor and just kind of keep those in the back of your head. Look at sleep. Is sleep a factor? Is stress a factor? And you can see it in their CGM data, you know, kind of this is a clinical pearl when you're watching CGM data. When I see someone with elevated numbers, especially if they, you know, they haven't been sleeping well, their blood sugar numbers fasting will be around like maybe 120, maybe even 140, and they're not coming down. And they eat a meal, even if they eat oatmeal, you just get this like blip and you get a blip and you're like, oatmeal, really? But they get a blip and after they eat, then it starts coming down. That's the first time you see their blood sugar coming down to like 100 after they eat. And that's my sign. I'm like, oh, this is cortisol because cortisol will get the liver producing glucose in the bloodstream. But because that is just in the bloodstream, it doesn't trigger the GLPs, the incretins, to stimulate the insulin production. But if you put food in the gut, it's better at triggering insulin. Insulin comes up, takes care of that oatmeal, and brings all the rest of the blood sugar down. So when you look at CGM data and fasting baselines trucking along high, they eat, it goes up a little, and then brings everything down. That's always a sign that this might not be food related. This might be, there's probably some kind of something's raising cortisol.
So have you had patients that were not on GLPs and then on GLPs on CGM prior and after? Have you seen changes?
No.
Okay. I'm really curious. We have a couple patients, but all of them have been on the GLPs already when we started the CGM. So yeah, I was curious.
So I'll give my short experience with it. I'm not on GLPs, but I try all of our stuff. And so I think I did it for like a couple weeks and I had my CGM and it definitely controlled my spikes and it also helped my fasting. And again, that's me personally, right? I mean, everyone is so metabolically different.
Yeah.
But then that's when I started to notice just like the little things that I do in my life, like stevia, chew gum. And that was pretty eye-opening, you know, things that you wouldn't think, sugar alcohols.
Yeah.
So like you said, I think the key is anyone that's looking to, learn more about this, you need to do it yourself. And
Yeah. Yeah.
And it's not expensive. It's super eye-opening.
Yeah.
And now they have a resource. I mean,
Yeah.
it can be obviously so valuable.
And you know what? Just to tie in, bring this back to the GLPs. Can I share my screen? Because there's a bit of research that came out. I think I've shared this research with you before. Just to show you the variability in insulin response and where the incretin effect, incretin being, you know, the GLPs and GIP in the gut. This is a publication that came out in December, Nature Biomedical. What you're looking at are people with normal blood sugar. Most of it is pre-diabetes, and a couple of these people have type 2 diabetes. This is the C-peptide concentration after a glucose tolerance test. And the blue line is IV, would be like IV, and the yellow is an oral glucose tolerance test. So the difference between the two lines is the incretin effect on C-peptide or insulin production. That's how they're measuring it. So what's interesting is these are the normal glycemic patients, and these are all pre-diabetes. And like, it's incredibly different. It's so different. There's so much variability, heterogeneity.
Well, and I think another really super important point, you know, to even just start to wrap this up is that these GLPs it's not just about getting people to never eat again, right? You know, I mean, they can really help restore that foundational metabolic health, right? I mean, has so many regenerative uh, components to, like, you know, the pancreas and the beta cells and things like that. So, and that's obviously what we talk a lot about. We are not like 100%, oh my God, we love them. Everyone needs to be on them. But it is really, really understanding what these GLPs can do from a foundational metabolic health perspective. Because if we can get people, you know, it takes, you work so hard to get that blood sugar, get that insulin down. When you can kind of accelerate the process, you know, that's just going to help, you know, in so many different ways.